Welcome, everyone. It's the top of the hour.
Talk about our development program for sparsentan, and it's an honor for me to be presenting on behalf of the company. This is a pretty high-level group of people, so I hope to talk briefly to give a chance for our expert discussants to take your questions and discuss this whole field. The invitation to us is very welcome. The first issue about this is balance. I've been invited to talk about sparsentan and our program, but of course a balanced talk about innovation in FSGS and IgA would include a number of other programs. So I'm going to accept that I will be unbalanced. I'll talk about sparsentan in some detail, but at the end of the talk I will come back to the context and try to put this into the context of the other programs which are taking place to restore a bit of balance to the occasion. Let me first indicate a caveat, which is that sparsentan is an investigational product, not a licensed agent, and therefore everything I say about its potential for patients is ineffectively to be said with the additional phrase, if approved. I won't keep saying that, but that's what I mean, and I'm going to talk about this program for educational purposes, not to induce anybody to use the agent pre-approval. So first, a few things about Travere. We are a biopharmaceutical company specialized in identifying, developing, and delivering life-changing therapies to people living with rare disease. Our pipeline is led by sparsentan, which is a dual endothelin-angiotensin receptor antagonist, and it's in trial for the treatment of primary and genetic FSGS and IgA nephropathy. We also have a program on TVT-058 or pegtibatinase for classical homocystinuria, currently in phase 1/2 study. We also have earlier innovative collaborations on a range of genetic and metabolic diseases. Travere has commercial products in the United States, which are indicated top right. Our headquarters are in San Diego, California, and we also have an office in Dublin, in Ireland. The focus of our company is very strongly the patient, and our chief executive, Eric Dubé, has created a very clear culture of patient focus. And I show in this slide a picture of 4 individuals with FSGS and IgAN who gave up their time to talk to us about how their diseases affect them. And this has been very inspirational for the whole company. We are aware of the unmet need, and we are aware that there is a great deal of work to do. Very briefly for this audience, the burden of FSGS and IgA nephropathy. FSGS first, a heavy proteinuria disorder. I'm talking here about primary and genetic FSGS. The disease is characterized by nephrotic syndrome and nephrotic range proteinuria. Current standard of care includes high-dose steroids, and despite current standard of care, only a minority of patients attain and retain a complete remission of proteinuria. So these patients are looking at a significant chance of progressing to end-stage kidney failure within 5 to 10 years. IgA nephropathy is a disease with a wide spectrum of severity. There are very mild cases, but data available at biopsy is able to stratify these patients, indicating a large group, perhaps as many as 40 or 50%, who are at significant risk of end-stage kidney disease within 10 years. In both of these diseases, I think there is clearly unmet need for improved therapies. And in the case of FSGS, to some extent IgA nephropathy, a burden of therapy due to the effect of steroids. So there is a great deal to do to improve the outcome for these patients and to develop new therapies in order to do so. Primary FSGS is a podocytopathy. This slide is a very brief cartoon about what can happen to podocytes when they're injured. And the point of this slide today is to say that all of these negative processes, all of these effects on podocytes, once initial injury has taken place, can be and are driven by a range of cytokines. Prominent among those are endothelin-1 and angiotensin II. And